So for this recall session, I'm going to be going over chapter, what is it? I'll be going over chapter 2, which covers the patient and family response to the critical care experience / critical care environment. So based off of what I've labeled in the book, I'm going to be going over and writing down everything, all of the objectives for this chapter. So for objective 1, it talks about analyzing the effects of stress and anxiety experienced by patients and their families in the critical care setting. So in regards to that first question, show my whiteboard. So some of the top 2 complaints are noise and light. Noise and light are very important in the ICU because it provides almost too much sensory input, which causes sensory overload. And noise, for example, can be outside conversations. It can be all of the alarms going off. It can be like if the doors are left open of other patients' rooms, so that's why we want to try to keep the door closed. And then lights. Lights are needed for the nurses because we can't have the lights being dim because then we're not going to really be able to see what we're doing, especially for ICU procedures that are very important and need light. And then discomfort, such as whenever someone is having like a phlebotomy procedure, they're going to be extremely uncomfortable, and that's going to give a sensory disturbance. Sleep deprivation because of all the noise. So it is the noise that causes sleep deprivation and delirium, which we will get into later. Constant interruptions. Can really cause a patient to have like anxiety, not as much anxiety, but like they'll lose sleep. Like if you have a patient where you go in there like every 15 minutes for vital signs, or oh, now I need to draw labs, that can cause them to lose sleep and rest, which they do also need, and that's very important. So that's why it's better for us to cluster our care and get as much done as we can at that time and point. And lack of sleep, which we said is also a reason for constant interruptions, but also because of the noise and the light. And then, of course, there's the sensory disturbances like we talked about, like certain procedures, things like that. Also anxiety. And then family. Family can also have these problems too, especially if you have a family member that stays with the patient. They're going to be annoyed and interrupted by this kind of stuff too. Now next we'll talk about, for objective number 2, formulate nursing actions that may reduce or eliminate stress and anxiety in the critically ill patient. So whenever it comes to things we can do to help with these disturbances and these stressors, so things we can do, we can adjust, which I'll show, like I'll flip the camera around. So we can adjust the alarm noise. So for example, an alarm being like from certain equipment, adjusting that alarm noise, especially at bedtime, is very important to promote good sleep and reduce stress. What else? Dimming your lights and trying to use as much natural light as you can, because those lights can be very, very bright in the ICU. So if you constantly have the lights very, very bright, that's not really promoting sleep or rest. Like we talked about, clustering your care, that reduces constant interruptions. Closing your doors, like whenever you talk to the patient or whenever you leave, if you leave the door open, that's going to make the noise louder. Avoiding loud talking, and also answering your cell phones very quickly, that can help reduce like the noise aspect. There's many complementary therapies, such as like guided imagery, using soft, gentle noise like songs, which is also called sedative music. It kind of helps promote sleep as well. And then when it comes to your patients that are like unconscious, so believing it or not, patients that are unconscious can actually still hear, understand, and respond emotionally to what's being said. So we still want to talk to them as if they were awake, and it's very important to reorient them, like, hey, Mr. Whatever, it's Monday morning, 8 o'clock, you're at this hospital, we're treating you for this. And just really being there and really reassuring them and reorienting them will help reduce stress and anxiety. And then lastly, for your patients that are awake but have sensory deficits, providing stimulation and talking to them and encouraging the family to talk to them. Also, like having family photos or family belongings around could kind of help, uplift their spirits a little bit too. And then the third is evaluating the importance of including the family in the care and during the actions to address their needs. And everything I wrote down for objective number 2, by the way. So as far as evaluating the importance of including the family, so we will go more into it later, but the family is actually key in a patient's care plan. So families are in a vulnerable state, first of all, because they're very stressed out. The ICU is foreign to them, so they're not really sure what's going on. They're not really used to that environment. The family can actually provide really, really good, valuable information for the development of the care plan. And then most importantly, we need to do a family assessment. So we need to do a structural assessment, which is identifying like immediate family, extended family of that patient. And then there's a developmental assessment, which includes information related to the patient's developmental stages and tasks. The functional assessment, which reveals how many family members, how they function in relation to one another. And I'll write this down on the board and I'll go more into detail here in a second. So really, other than what I've said, because the other stuff will go into detail more, there's not really anything to write down. But what else I'll say is the family, they really want to be involved. So as much as you can involve them and update them with the care plan, let them kind of help out with your procedures if they're able to. Let them be a little hands-on. That way it gives them some type of control. That way they feel like they're important for the patient and helping out. Maintaining privacy. Like whenever you talk to the family and the patient, make sure HIPAA and you're, giving them privacy. That way they feel like, that you're respecting their privacy. Giving assurance and building that rapport, again, that builds trust. And the best way to do that is through communication, especially making sure like it's in their language and within their cultural guidelines. And also like updating the family will show that the requirements are being met as far as like they want to know what's going on. That's going to increase their stress if they don't know what's going on. So updating them and letting them go visit the patient, that's very important too, which we'll get into more later. And so that is that for right now. So examine how assessment of the family and their history can assist the nurse with providing holistic nursing care. So for this one, a way that the family assessment can really help you as a nurse to provide holistic care, which has to do with like spirituality, culture, which we'll also go into later, as that's one of the next objectives. It can really reveal the emotions about the family. So they can have emotions such as, like, the family assessment can help you identify whether the family is angry, guilty, they have concerns that are not being met. Like, for example, like they have concerns that aren't being answered. So like if you're doing something on a patient and you're not even updating them or telling them what's going on, they're going to be like, okay, what are you doing? Like, it can reveal emotions about the family, and that can also bounce back on the patient too. The patient might be having those same emotions The assessment can also show a family's issues, like what other issues are going on that could be causing stress, in the environment for them. Do they have beef with the patient? It's always good to know these things. And then also in the family assessment, they can express their needs. That way we can know what we can do, who we can reach out to, like a chaplain, and being there to comfort, support, and listen to them. And that will be one of the next things we'll go into also, is how to enhance your communication based on the family's needs. So next, number 5, recognize behaviors of family members that demonstrate their inability to accept the patient's condition. So this one's pretty simple, so there's no reason to write it down. One that really spoke out to me in class that I think it's really talking about: if a patient's family member, if they are worried about, if they have how do I put this? If they feel like they're not in control and helping out with the patient, or if they're having like memories or flashbacks from like past moments when the patient wasn't doing well, this can show a feeling of guilt. Like, oh, why wasn't I there for this patient more? This family member more. Why wasn't I there for them? I wish there was more I can do, but I can't. That kind of thing is like guilt. So that's something we can look for. Another thing, they're going to want confirmation for everything. That's why it's important, just as you go, just to update them. For example, if you're waiting on a lab, tell them, hey, I just requested this lab. Or, hey, I was just told that we should be getting lab results within the next 20 minutes, just so you're aware of it, and I'll let y'all know how the results look once I get those. Those little things like that. And even if it's something that's like way in the future, but you just wanted to kind of put it in their ear, that can also build rapport too, because it shows that you're really involved in that patient's care plan. Let's see. Next one. Examine nursing interventions that may be useful to help patients who are facing a loss. Okay, so when it comes to loss, that's really going to affect how the family copes. They might have healthy coping behaviors, or they might have unhealthy. Like they might medicate with alcohol, they might medicate with drugs. And whenever someone's going through a loss, they're not able to completely think properly. They can also have triggers. So identifying the triggers, teaching the family healthy coping habits and people that they can reach out to, support groups, stuff like that, and telling the family it's good to be there for each other. But the number one thing in a crisis, whenever it comes to a loss, is safety. Because people are not thinking rationally. Easily, a bomb can just go off out of nowhere. So making sure you keep them safe is key. Also, when it comes to just like normal nursing interventions to help a family out, decision making. Making decisions, helping the family make the decisions for the patient. It gives them some control. Communicating with the family and the patient, prognosis, updates, what's going on, and maintaining privacy like we talked about. Communication, updating the patient like we just talked about as well, and giving that information to them in a variety of formats. And remember, we don't want to use medical jargon. We need to make it very simplistic. Plus, they're already stressed out. They're not going to be able to have an overload of information. So we really need to make it simplistic and give them reassurance and build that rapport. Also update them with everything that's being done and be there to support them through all of this. So that's what we can really do as far as interventions, as far as that goes. So next we're going to be talking about specifically spirituality and its role. So with spirituality, we need to, first of all, because culture and spirituality kind of go hand in hand, we need to identify what culture they are. We need to respect that culture. and see what their spirituality is. We need to identify the primary language, and remember, if English is not their first language, we need to get an interpreter. That way there's no gaps in care. There's nothing that's being left out that is important. There's nothing that we're telling them that's being left out. We want everything to be clear. And as far as the cultural and spiritual assessment, there are 3 questions that are good to ask. What are your specific religious and spiritual practices? What are your beliefs about illness and death? And then what are the most important needs to you and your family right now? Because spirituality, culture, those are mainly important for providing and seeing what needs the family needs. Because if we're not meeting those needs, then it's just going to be, like another crisis. And as far as this goes too, assessing those spiritual needs can be incorporated into the care plan. For example, if they need to talk with a chaplain, you arrange for them to talk with the chaplain. And also, if you can, just kind of let the staff know what their culture, ethnicity, spirituality is. And maybe we can try to get some people that are of that same culture, ethnicity, to come talk to them. Maybe that can help them because they can relate a little bit better since they're of the same kind. And next is using the value mnemonic to enhance communication skills, which I will write down on the board. Before I go on to that, I also wanted to mention, this isn't necessarily on the objectives, but just being aware of PICS, which is post-intensive care syndrome. That's where so post-intensive, so after the ICU, this is where patients can experience psychiatric problems, cognitive dysfunction, or disability and weakness. Those are effects post-ICU. So just being aware that the ICU can even affect them after they leave. And it can also give them certain emotions. Like the patient could say, oh yeah, it brought me anxiety, depression, loneliness, fear. It brought me physical problems such as dysphagia, difficulty sleeping, communicating, not feeling like they're in control, feeling a lot of pain, thirst, thoughts of dying even, and they'll feel like they were in a physical restraint because whenever you're in the ICU, you're very limited to what you can do, especially with what your condition is. So now we'll go over the value mnemonic. So, mnemonic, we have value. So valuing their words. So if you remember the mnemonics value, remember we're valuing what they're saying. It's very important to us. We can appreciate where they're coming from. Then acknowledge their feelings. Empathize with them. Show them that, okay, I see what feelings you're exhibiting. I can understand. I see that you're feeling this way. Listen. As nurses, we have to be active listeners. It helps us learn more about them because we don't want to talk too much and then not interpret anything that they're saying. Understanding the patient as a person, as sometimes as a nurse, we feel like we're just treating an object. We don't remember that they're actually a person. So remembering that the patient's a person and really trying to get on that one-to-one connection with them is important. And then lastly, eliciting questions with the family. And that goes for any kind of questions. And then empathizing with them is what I also count as that last E. Break down the positive and negative aspects of the ICU. So, some places are very chill with letting your family come in. Some are extremely strict. It just depends on the policies and the hospital at hand. Some nurses may not even accept, if it's a very relaxed visitation policy, the nurse might be like, oh no, no, I don't want them back here. It's going to be more stressful. But really, it's not, because an additional concern is that family members will be intrusive, creating burdens for nurses. However, concerns about negative outcomes are unfounded, and sometimes allowing the family to go back there, like, you think they're always going to be in the way, but they're really not, especially if you keep updating them like we already talked about. Usually, as a nurse, you should keep your visitations open. Let's see. And then as far as, I know this is objective number 11, but research issues regarding visitations of children. So with children, obviously they need to be supervised. It is the ICU. There was research showing that many institutions prohibit children going back there, but if they're supervised by an adult, then it's different. And nurses need to be engaged with the visiting child. And as far as that goes too, it kind of shows the child an opportunity. It gives them an opportunity to learn about what that family member of theirs is going through. And it also allows them to get some support too, because they're very uncertain about everything that's going on, especially depending on their age. Oh yeah, we were on number 11 anyways. We didn't skip over any of them. So examine issues regarding the presence of family at the time of death and during a code. So that I will probably go ahead and write on the board. So actually, I think for this one it's pretty straightforward. So evaluating and examining the issues regarding the presence of family. So most people would think that family will like get in the way at a code, but imagine being there during a code. Even as a CNA, this has happened to me. You're kind of like in the background. Like you're freaking out. You're not going to interrupt during a code. But there are some downfalls about letting families come in, because there's limited space at the bedside, especially with all of the different healthcare workers that are in there. If someone's violating patient confidentiality, people don't want the family to know that. Sometimes there's not enough staff to assist family members, because we need someone in there talking to the family too. And if we're not doing anything in the code, that's what we can do. We can talk to that family, explain to them, okay, so what they're doing right now, they're giving a patient epinephrine. That helps. You wouldn't tell them sympathetic. It would increase sympathetic activity. But you would tell them, this is going to help increase their heart rate. This is going to help, this is going to help them breathe better. Things like that. Because epinephrine speeds everything up when everything's slowed down. And then allowing the family, so those are the negative effects. Positive effects, it increases knowledge of the patient's condition, and 2, it shows to the family that everything is being done. That's the number one thing about codes and why families should be present, is because they're going to think that if you're not letting them be in there, that they're going to be worried that not everything that needs to be done is actually being done. And then next, evaluating the importance for the nurse to recognize and appreciate the cultural differences of each patient and incorporating those into the care plan. So that has to do with, like we said earlier, assessing the spiritual needs and incorporating those into the plan of care, as well as their cultural needs too. And that was for number 13. And then something else that is not on the objective list, but it's something in the book that I think is good to know. It's called the family bundle, and it is on our key terms list. And the family bundle is also known as EPICS, which is another mnemonic that I will go over. So kind of like how value, like we talked about earlier, kind of helps with communication. EPICS. This is the family bundle, and this is what helps with, let's see, providing structure for planning and carrying out family care. And it has positive results. So, EPICS, evaluating by assessing. We're assessing the family background. We're assessing their coping skills, their needs, what stressors are going on, and figuring out how much they really want to be involved. Planning is figuring out how to meet their needs and giving encouragement. Involving the family, like we talked about earlier, family participation, like within their, like if you're doing wound care, maybe they can hold something for you or, stuff like that. Just little things. The little things really help and help them feel like they're in control. Another way you can involve is like we talked about earlier, how we could even have them bring family items from home. Communication, assisting in communication with other providers, encouraging conversation, open-ended questions, answering questions honestly, and being simplistic with our answers as well. And then support. Support's pretty self-explanatory, and it's for the family and for the patient. So that's EPICS. Analyze how noise and continuous bright lights in the ICU can negatively impact patients. So I feel like objective 14 is kind of like the same exact thing we talked about for the objective for number 1 when we were talking about like things that cause stress and anxiety. So again, lights, noise, just discomfort in general, like from a procedure or something, the sleep deprivation that's caused from noise. Remember that noise is what causes sleep deprivation. Also remember they're constantly being checked on and things are being done to them. So that's going to cause anxiety. That's also going to cause stress, and that's going to cause lack of sleep. 15, evaluate the negative effects of sleep deprivation. So that's what we have been talking about kind of all throughout this video. So that's something I'm going to be writing down since I feel it's pretty important. Okay, so remember when Professor Granger talked about we need to know delirium. Delirium is a form of sleep deprivation because sleep deprivation and delirium are both from a lack of sleep. And what's a lack of sleep from? The noise. So delirium, it is an acute state, mental state of confusion and disorientation. And delirium, remember, don't get it confused with dementia. Dementia is progressive and irreversible. Delirium is reversible because delirium can be caused, the causes of delirium are easily reversible. Like with sleep, they're losing sleep. We need to promote sleep, get them something to help them sleep, right? And even medications, certain medications can cause delirium, which in that case, you would, figure out if there's another option for the med change. So what are some signs and symptoms of delirium? So a really, really big one is obviously they're going to have a state of confusion. They might freak out a little bit because they're not really going to know. Because then whenever someone's confused, think about it. If you're in a room and you're like, this isn't my room at home, they're going to be freaking out. They're going to be very anxious. Very anxious. But a really big one too is hallucinations. Like you're talking to them on normal and then all of a sudden they don't realize who you are, or they're like, oh yeah, I see Michael Jackson in the corner over there. No, it's a hallucination. That's delirium. And some medications, I don't think we really need to know like what medications to give, but some medications that you can give is like Haldol. Remember, Haldol is an antipsychotic. It can calm the patients down and sedate them. And then there's even like seizure medications like phenobarbital, for example, is probably one that we can give, or like lorazepam, something like that. So that is that. And then the next one, which follows up, outline nursing actions to increase rest and sleep in the ICU. So promoting rest and sleep are very important. And ways we can do this, like we talked about earlier, dimming the lights, dimming the noise, providing sedative music, finding ways to increase comfort, like you could even use complementary therapies. Again, aromatherapy, guided imagery, which can kind of help calm them down and make them fall asleep. Promote day-night cycles by positioning the patient near natural light during the day and then reducing light levels in the patient's room at night. Because this can also kind of get their brain used to like, oh, okay, the lights aren't that bright right now. Okay, my brain is saying, all right, it's getting close to nighttime. And then, like we said, reducing noise, especially during nighttime hours. The same thing with lights. Assess strategies to decrease sound and sensory overload. So in that case, we need to identify the stressors, because think about it. Whenever we assess, what are we doing? We are assessing the patient. We're trying to figure out what's causing this problem, what's going on with them. So we need to assess or figure out the stressors. What is irritating them at this point? What is it that's bothering them? Is it the ventilator next door in the other room? Is it their bathroom light being left on? Is it their door being open or being cracked? Is it their curtain not being closed? What is causing this disruption? So knowing and pinpointing exactly what is stressing them is obviously, once we assess, then we intervene. We do and fix the problem by intervening once we figure out what the problem is first. And lastly, our very last one, which we already kind of talked about, exploring the use of complementary therapies. That's another way to decrease sensory overload, stress, and anxiety. And it can promote sleep too, because it relaxes them, right? So we have therapeutic touch. If they're stressed out, anxious, touch them. That shows them reassurance. That shows them that you're there for them. They can talk to you. They can express any concerns. Relaxation, of course, promoting that sleep like we talked about and what to do to promote sleep. Music therapy, so like sedative music, for example, like we talked about earlier as well. And then guided imagery. If on their TV or on your computer, you could even use your computer. Show them their favorite place. You can show them a picture, or you can have them close their eyes and imagine. If they tell you, oh yeah, the beach, that's my favorite place, have them close their eyes and imagine that they're at the beach amidst the stress and noise and lights and their health and everything else that's going on. So that covers the ICU environment.